another video. This video goes with lesson 4 discussion boards, where I think we asked for a generic question and answer opportunity. And I saw where we had some really good questions and everybody was helping each other out. So that's as it should be. Thank you so much. Someone asked a really good question, really a question that encompasses all questions. That is, what is the best way to help someone who is an addict? And there's no right answer there, because everyone's addiction is really personal and it's different, and there's no one script. And if we're looking for answers out of a book to provide to everyone, and if we expect success, that's just not going to happen. There is no one best approach. What we do have is some best practice in terms of what has worked in the past for the majority of people, and we have new ideas out there in the field, and we have conversations and debates, and we're gaining a new understanding of addiction through brain science and some of the videos that you watched in medication. But if someone were to ask, what is that magical combination? There is no silver bullet. It doesn't exist out there. What we do know, though, is a combination of traditional counseling treatment in a formal setting and self-help groups tends to be most successful for the majority of people. Others, medication needs to be into the mix. Not only medication in terms of what we call drug replacement therapies, such as methadone and Suboxone, which is a drug that attempts to decrease the urge to use, or does not allow the person to gain the same high, or for the drug to have the same effects. That's one type of drug. Another type of drug is your classic drug that's used to treat psychological symptoms, such as depression or anxiety, phobias, or that type of thing. For example, with crack addicts, cocaine addicts. Initially, helping a cocaine addict find sobriety and clean time is not that hard. But what happens with cocaine damages your pleasure sensors and serotonin so much in your brain that it really messes with your levels. And when the client stops using, in about 3 to 4 weeks in, what happens to the client, if they've been using for a long time at really high rates, is what we used to call cocaine depression, which means the person who is trying to find sobriety tends to really bottom out, and they go through a long period of severe depression. And that's the period of time that the client is at most risk for relapsing, because if you go from experiencing a high state the majority of the days, you stop using, and 3 or 4 weeks later, you not only have to start dealing with problems in your life that you have to start admitting and acknowledging and having conversations about. You not only have that going on, but within yourself, within your brain and body, you're experiencing a significant bout of depression. So what's the easiest thing to do? Well, the easiest thing to do is to use again, because it will, again, help you with those outside problems. You won't have to deal with those outside problems going on around you, and it will elevate your mood at the same time. And in that way, this is one of those examples where addiction makes sense. Those negative consequences, why would someone use with the negative consequences? That doesn't make sense. But someone using again to decrease pain, that makes sense. Hitting bottom was another concept that some folks brought up. This is another controversial concept. Some people believe that you have to hit bottom, meaning in the bottom throes of despair, psychologically, physically, environmentally, with family, that type of thing, before you can ever see your way out. Others believe that's not possible. Your book basically says that DuPont believes that someone has to reach the end of their rope. He believes in order to make the decision to change their lives. I'm not sure what I believe about that, to be honest. I've been in the field since 1995, and the jury's still out. I think it's different again for everybody, as is all these topics and conversations. What does family do to help the addicted family member? Not enable their behavior. What do I mean by enabling behavior? That's the topic of our next lesson, so I'll kind of tease that one and our conversations and videos about Al-Anon and Alateen and so forth. So let's hold on to that one. What's the definition of chronic? Chronic use is generally daily use. Chronic use is use that you can never really get rid of, meaning if you have a chronic disease, it's a disease that stays with you forever, such as diabetes. Diabetes is a chronic disease. No matter what you do, you have diabetes, as opposed to an acute problem. In medical terminology, an acute issue is a issue such as a broken arm. You walk into the emergency room, you have a broken arm, that's an acute issue, and hopefully several months, years down the road, the arm is repaired. And you may never have issues about that particular arm again. Someone asked about methadone and Suboxone. Are those addictive? Generally not. Methadone may be if it's in controlled use, although I think that's somewhat overblown in society folklore. It is technically, yes. Suboxone, some clients say they can get high off Suboxone. Maybe it may give you a sense of euphoria, but it's not the same addictive high. The Suboxone doesn't have any addictive substances within it or chemical compounds, so it can't be technically addictive, but it can give you a buzz if it's misused, as other drugs can give you a buzz if it's misused. Again, methadone and Suboxone are examples of drug replacement therapies. They're not the only ones. Methadone has received a really bad reputation in the community, not necessarily because of the drug, I firmly believe, but because it's been misused and misprescribed by medical authorities and treatment clinics. If we look at the best practice and what we know in terms of how to use methadone and what helps clients the best, is methadone should be used as a replacement therapy, very short term, even as little as 6 months and no more, in coordination with monitoring, which means drug testing, and clinical treatment for over a long period of time. And what's supposed to happen is you may start with a really high level of methadone, and as the person progresses, the level should decrease. And you may see the counseling services increase and other support services. But unfortunately, what happens is we prescribe folks methadone and we keep it at the same level because we say, well, the client's not ready to step down. Well, the client may not be ready to step down because they may not be ready to stop using, number one. But number two, they are not receiving any other supportive services as well, or any other motivation to decrease use. So in that case, yes, we may be replacing one drug with another. But what we do not hear about is all those success stories with methadone. Methadone has made a dramatic and serious difference in the lives of a much greater percentage of people who was using heroin and narcotics than those who visit the methadone clinics to get high. And we just don't hear about the successes, but we do hear about all those people who are not successful. And that's very true about addiction in general. We hear about the individuals who are not successful, but we don't hear about those who are successful. That's why the public doesn't understand concepts behind addiction. Methadone is also used most frequently because it's cheap. Dosage amounts are extremely cheap, a couple of dollars per dosage, if that. It's a well-known quality, been around for 30 years, and so forth. you can look at methadone maintenance in a different way as well, in terms of quality of life. The percentage of individuals using methadone going out there committing serious violent crime is much lower than those using heroin or cocaine. But usually you're staying with those narcotics. So in terms of public good, would you rather have a heroin addict or other narcotic addict out there committing violent crimes, stealing to support their habits? Or would you rather have a methadone addict who is misusing, who isn't breaking the law? In terms of public good. In terms of public good, I would rather have the methadone addict as opposed to the narcotic addict. Suboxone is extremely expensive, $400 to $600 per month. Methadone may only be less than $100 per month. It's one of the newer drugs where when the client takes Suboxone as is prescribed, if they use their drug of choice, they will not get high. Suboxone acts as this wall between the drug and the chemical reaction in the brain. It also lasts for a couple of days. Suboxone is being used very frequently to great success. But again, if we don't involve counseling and other types of supportive therapies, success is lower. But Suboxone is the current great hope in terms of treating addiction to painkillers and opiates. And the jury's still kind of out. But it works extremely well for many, many people. Some other issues. How do we ensure the greatest success? It's a combination of approaches: treatment, medication, if needed, and meetings, self-help meetings. Employment is a big issue. Users who can find employment have much greater levels of success than those who cannot. Some other issues: stages. Someone mentioned the stages of addiction. Again, these are just stages as a framework. It doesn't necessarily mean that 100% of the time this is what works for everybody. It's a stage. It's kind of like the weatherman. So all addicts don't go through all stages. Everybody doesn't hit rock bottom either. This is a very, again, individualized process. But we're talking about stages a lot in the substance abuse counseling program or counseling class. If you take that class, many of these topics would go into in great depth. So if you're interested in addictions or substances, you may want to take that particular class. Relapse is a lifelong struggle. I've known individuals who were clean for 30 years who relapsed. They only relapsed one time, and maybe that was it, and they started working their program again. I've known individuals who were clean for 30 years who relapsed, who were on the streets for 18 months, 2 years for good until they died. So relapse is a part of the recovery process. Usually my philosophy is everybody relapses. If you don't relapse, you were never addicted. You're only misusing drugs. Relapse is part of the recovery process. And we have to start talking about relapse and preparing clients for relapse before it happens during the treatment process. Last but not least, someone mentioned the genetic processes. Again, just because you have the genetic code, your parents, grandparents were alcoholics or addicts, doesn't mean that you will be. It's just one factor in a variety of factors, such as environmental, such as how you deal with problems, your tolerance for stress, your environment, your willingness to take risk, the type of drug that you use. So genetics by itself is just one slice of the pie. And if you look at the beginning chapters of your textbook and the videos, we talk about what some of those other factors are. So I do hope this helped. And please send me any questions you have. Take care.